We always say that we don't cross dura or arachnoid, but he is a full-fledged neurosurgeon. The Madras Medical College is very proud to say that he is our product, and I am so happy to say he is my MBBS, DLO, and MS classmate.
Thank you. Thank you. Good evening, everybody. So, first of all, thank you for the nice words, Mr. Moderator. I first of all thank Professor Seema Sheikh for having invited me here for this very prestigious event held by CIPLA. Thank you very much. And I should really thank my teacher, Professor M.K. Rajshekhar. I am not sure if so many have heard him actually giving lectures. To me, he is the best teacher I have ever met. So I really thank you for making me what I am today. So another important character who is sitting there is Professor Anthony, and I call him the encyclopedia of ENT. You know why? Because whenever I have a doubt, immediately I'll phone up and ask him, can I do this? And he just spontaneously answers because he knows, is read so well read. So thank you for moderating the session. So with a kind permission of the moderators, what I'm going to do, my lecture is around 1 hour. They've given me 1 hour for JNA. I'm going to split it into 40 minutes. So I'm just going to talk for 40 minutes, and 20 minutes I'm going to give it to the audience. So we're going to be very interactive, and you can ask me or say or comment and do whatever you want in that 20 minutes. Okay? Let's make it like that. Is it okay, Mr. Moderator?
Okay.
Perfect. So first of all, I want to dedicate this presentation to my teachers. So I always say teacher, teacher, because I always believe that teaching is the most noble profession on this earth. So I thank Professor Amin Kassam, Professor Karau, and of course Dr. Daniel Prividello. My concept of JNA, actually I started this, doing JNA in the year 1999. So that was the first JNA I did. And from then onwards, till 2006, I was not very good in concepts of JNA. But they gave me concepts on skull-based surgery, and I applied that concept of skull-based surgery into the surgery of JNA. And so I modified my whole concept of operating on a JNA, and that credit goes to none other than these three people. So I dedicate this to them. So I also thank CIPLA Orient, because this is being seen all over the world. So I can understand that there are so many people who are seeing this, a very good academic endeavor. And of course, I'm the academic head of neuroendoscopy, Karl Storz, Asia Pacific. Well, JNA. So we're going to talk about endoscopic approach to not JNA. So now, if you go to various conferences abroad, they have taken off nasopharyngeal, and we just call it JA. So that is the current terminology. The reason is because it is not arising from the nasopharynx. It was thought to be arising from the nasopharynx. So now the term JNA is out. And if you see the recent literature, it is just JA. So we call it JA, juvenile angiofibroma. So because this is the current terminology. Of course, I have the privilege of being a neuro head in Vietnam, Davao, and of course, now tomorrow I'm conducting an exam for neurosurgery fellows by ACNS. I think Dr. Ayap is watching me, and this has been headed by the ACNS group and Professor Yako Kato from Japan, who is the neurosurgeon who is actually moderating the whole thing. Okay, now, how is your JNA surgery going to be? You're all JNA surgeons. I know you're going to sit in this audience. In Goa, who will listen to JNA? I can understand your plight, but the very fact that you're sitting there means that every one of you is doing JNA. And if you want to do JNA, how do you do it? Now, this is how I will do my JNA. I want sound. The first is anatomy. Rise the volume. So your anatomy, sound de do bhai. So that's the surgeon, and that's the JNA. And that's how you pick up the JNA. Wherever it is, your anatomy should be perfect. And that's the first criteria for you to be a JNA surgeon. The second criteria is you should be extremely focused on anatomical structures. And how do you focus? That is the target. You see how you get into the target? This is how you get into the target. So you should be so focused on JNA that your focus cannot deviate. And that's how you really become a good JNA surgeon. And the third most important thing I believe in JNA surgery is the technique. So every surgery needs a technique. And if you are not good at that technique, the surgery is not good. And this is how I feel you should be a JNA surgeon. So you see that by pure technique, you can make an average UMG surgeon, an average JNA surgeon, into a fantastic JNA surgeon. So that's actually what I want every JNA surgeon to be. Anatomy, precision, and technique. So this is the three important features of a good JNA surgeon. Well, let's go on. So how did I really form this concept? Because this was not there before. Before I published this, nobody had published it. So this is the first publication which we made. We have now around 12 to 13 publications just on JNA. We are making 4 publications more. So we found that the smallest JNA, we had 6 cases. I really thank all the people who really referred all these cases. The 6 JNAs which were not nasopharyngeal at all. There is no nasopharyngeal component. It is just from the pterygoid wedge. Then is where I decided this is arising from a place called the pterygoid wedge. So then we studied all our JNAs retrospectively. Around 200 plus JNAs we studied, and most of the JNAs had this pterygoid wedge involvement. And that is how we brought out what is called the Ram-Haran sign. So what is this sign? We compared this width, the width here with the width there. And this was clearly found to be enlarged. And once we studied the parameters with our radiologists, then we published this sign. And you can see in all your JNAs that most of your JNAs will have, you would have read about Hallman-Muller sign. You would have read about Hounder's sign. All these signs are present only in less than 60% of individuals. Whereas if you see this sign, you will have it more than 90% of individuals. You can take your JNAs and retrospectively study. Well, now then we studied all the pathways, how this JNA spreads. Imagine this is the sphenoid sinus, and the sphenoid sinus has got the anterior wall and the lateral wall as the pterygoid plates, both sides pterygoid plates. The pterygoid plates unite to form the pterygoid wedge, and that is where it starts. Now, from the pterygoid wedge, it can easily move on. So how does a JNA spread? Through the pathways of least resistance, correct? Am I right? That's what is written. To me, it's wrong. So that is where when I studied JNA, I said, why are we following like this? It is wrong. Because if it follows the pathway of least resistance, where should it go from the sphenoid or the nasopharynx? Nasopharynx, which is the pathway of least resistance? Oropharynx. It should go from the oropharynx into the laryngopharynx. But I have never seen a single JNA going into the laryngopharynx. So why should we follow the West, who have got just 13 and 12 cases? Then I started studying, how does this spread? So when we started studying it, it then has a spread apart from the pathway of least resistance along the submucosal vessels. Well, then we started thinking, how does it spread? So number one, pterygoid wedge, pathway of least resistance, sphenoid sinus, pathway of least resistance, nasopharynx. From the nasopharynx, it doesn't go down. It holds along the posterior septal branch of the sphenopalatine artery. So the posterior septal branch is there. That is the artery. So it catches hold of the artery and goes there. And once it goes there, it sees a pathway of least resistance. What is the pathway of least resistance? The sphenopalatine foramen. So it sees the sphenopalatine foramen, and then it moves into the sphenopalatine foramen, into the pterygopalatine fossa. It is a beautiful tumor. If you understand this tumor, it's simply fantastic to operate on this case. Now, from the pterygopalatine fossa, you have the IMAX. It goes through the IMAX, and it goes into the pterygomaxillary fissure and goes into the infratemporal fossa. From the infratemporal fossa, where can it go? It can go with the pathway of least resistance or the vessels. It can go into the cheek, or it can go to the temporal fossa. It is so easy to understand this. And then, from there, if it goes, it has occupied all these areas. Then from there, where will it go? It will see upwards into the orbit. And in the orbit, what does it do? It goes through the inferior orbital fissure into the orbit. And inferior orbital fissure is the anterior boundary of the superior orbital fissure. So it goes into the superior orbital fissure. Superior orbital fissure is the anterior boundary of the cavernous sinus. That is how it spreads into the cavernous sinus. Now, imagine this JNA is starting from the pterygoid wedge. It moves like this, it moves like this, it goes like this, it goes like this, it goes like this. And this is what is called, I named it as the anterolateral spread. So this is how I came to the concept of this JNA moving anteriorly and coming laterally, and this spread, we named it as the anterolateral spread. Well, then the JNA is not being removed by the doctor. What will it do? It will start growing further, but it doesn't have space to grow, so it grows posteriorly. That is where it starts spreading posteriorly. What is the pathway there? The pathway is the cancellous bones of the greater wing of sphenoid. And that, it goes, where does it lead to? It leads on to the Meckel's cave. It leads on to the Meckel's cave, and that is the quadrangular space. So it goes to the quadrangular space, it goes to the Meckel's cave between the paraclival carotid and the horizontal carotid, and then it spreads. It respects the dura. Most of the cases it respects the dura, but I'm going to show you so many cases where it has entered into the dura, into the brain. So this is the main core of this lecture which I'm going to give you. So how does JNA enter into the intracranial cavity? So this is what we're going to discuss today. So this is what we actually did of our 241 cases. Now we have done more than around 300 plus cases of JNA, and then we formed the staging system, and then of course we published it in the SNI. So what is the, many people ask me, why did you bring a staging system? I said, if you take generally the JNA surgeons, what they do is they use either cautery or a bipolar or a cobblator. These are the three equipments which they use, and just like that they start, either using the diathermy over it, or they use bipolar over it, or the cobblator over it. Even yesterday I did a JNA. I did 2 JNAs yesterday. If you see me doing a JNA, I hardly use coblation. I hardly use diathermy. I hardly use bipolar. Because I feel if you understand the root, you don't need to use anything. The blood loss is less than 20 ml. Our blood loss statistics, according to the world, we had a debate in European Congress, was the least among the world giants of JNA. So what I'm telling you is this is what we published, and this is the staging system which we actually follow even now when I ask my residents to stage. So let us see that stage A. So I'm going to illustrate that for you. So this is the pterygoid wedge. It goes into the sphenoid sinus. That is stage 1. So then again you can say stage 1B. So you can ask me, why are you, what is the difference? What difference does it make? You're just having just stage 1, stage 1A, 1B. Yes, it makes a difference. Because if you want to tackle JNA in the sphenoid sinus, you have to attack it by removing the posterior end of the inferior turbinate. So I just brought in one step extra for every stage which progresses. So if you look at my JNA surgery, it is almost like mathematics. It's like 1, 2, 3, 4, 5, 5th step, it's out. So it is like that. So you're going to see how we're going to tackle these stages. Stage 1B is like this, and then stage 2A is into the pterygopalatine fossa, stage 2B is into the infratemporal fossa, stage 2C is into the cheek or into the inferior orbital fissure, and then comes stage 3, which is in the quadrangular space. That's the posterior spread. From stage 3, it is all posterior spread. And then it is in the cavernous sinus. You can see that. And then comes 2 difficult areas to treat. Number 1 is the lower parapharyngeal space. If you have lower parapharyngeal space involvement, it becomes difficult to operate on a JNA. So endoscopically, this is all endoscopic classification. And if you see this 4B, it's going intracranial. It's going into the brain. So how do you deal with this? And then I got a stage called stage 5, where you have to do an external approach. So this is how we classified, and for each stage we have steps, specific steps to do it. So I've seen many surgeons, actually what they do is they just do endoscopic modified Denkers for all the cases. It is not required. It is absolutely not required. It's just an overkill for a small JNA. because if it's going to involve the pterygopalatine fossa, you don't need to do that. So we brought in a lot of steps. Now let us start our surgical videos. Now this is a stage 1A video. Now what will be the first step? If you read my book, you can clearly see a wide middle meatal antrostomy, and then you can see anterior posterior ethmoidectomy. You can see that beautiful tumor with a capsule there, that's a shell of the bone, and then you see we are removing, that's a superior turbinate, that's a middle turbinate, and then you remove this piece of bone. And then what we do is what is the blood supply for this JNA? It's the posterior septal branch. You just coagulate the posterior septal branch, this JNA dies. It's a dead snake. And then you can just pull it out. But please understand that we brought in a very important thing, which is even now followed in all around the world, that is drilling of the pterygoid wedge. So we drill the pterygoid wedge, see the median nerve in every case, and then you can see that's the median, that's the V2, that's lateral recess. So that is the complete excision. Unless you drill the pterygoid wedge, you will get a recurrence. This is for sure. So this is something which I want to emphasize, and that's the important carry-home message. And always, 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 please, if you do a JNA, take a post-op 36-hour CT scan with contrast. And this is something which I hardly see in many people, because they postpone it to 3 months or 6 months. This is something wrong. You can't do this for sinusitis, because in sinusitis you'll find residue, but in JNA you will find that JNA back. So it is not a recurrence, it is a residue. So what is the difference between a residue and a recurrence in JNA? 36-hour post-op scan is the hairline difference. If you say your 36 hours post-op scan is normal, and then the patient has again a JNA after 3 months or 6 months, this is a recurrence and not a residue. This is how we differentiate between recurrence and residue in JNAs. Now let us see a 3A. 3A, I told you, is involving just have a look at it, how it's involving the superior orbital fissure. This is the scan. I always read only the scan. I don't have MRI into my account at all. That's superior orbital fissure and anterior wall of the cavernous sinus. That's the anterior clinoid process. The cavernous sinus starts from the anterior clinoid process. We always do four-handed surgery for JNA. You can see that I'm doing a modified endoscopic Denkers, and you see that that's the nasolacrimal duct. We transect the nasolacrimal duct, and in fact, we talk about Daniel Simmons, we talk so often, he says, you could have just, translocated the duct, but to me, there's no difference. That's the IMAX. You can see the IMAX, and I clip the IMAX there, and once I clip the IMAX, you see that, that's the temporalis and the lateral pterygoid. And then what we do is, this is very important, to drill the medial wall of the orbit, and you see that V2. So always try to preserve the V2 in JNAs. This is something which is very important, because sometimes the patient will come and say, numbness, I have numbness here after your surgery. So that's because so that's the anterior wall of the cavernous sinus. You can see that that's a meningeal layer of dura. You can see all the cranial nerves going to the superior orbital fissure. I'm using a carotid Doppler to check whether that's the carotid artery. And yes, you get the carotid artery pulsations. We keep Surgicel, and then finally don't forget to do the pterygoid wedge drilling. So once you do that, then this is a complete excision of a JNA. So this is how we do what is called the centripetal approach. That is, don't touch the JNA, and you go around the JNA, and then finally attack the JNA, and after you get controls of the JNA. So that's about stage 3A. Now, coming to stage 3B, this I operated in Malaysia. This is a 9th revision. 9th revision, operated by so many stalwarts, not to mention any names. This was completely engulfing the carotid. This was the carotid artery right in the center of the JNA. And imagine you're operating in a different country, and this is a case given to you for surgery. And this is how we did this case. You can see that. Now that's actually, there's so many coiling had been done. So that they're all the coiling which was done. So that was the theater set up in the country. This is you can see that, and we are doing the four-handed technique. So infratemporal fossa has got 5 levels. Please understand there are 5 levels of infratemporal fossa. You should know at what level you're dissecting in the infratemporal fossa, because this is called the level 4 infratemporal fossa dissection. And then you see what I'm doing, that's the Petrus apex. So we are drilling the clivus. That's the clivus. Of course, I've edited that. If you want the presentation, I can give it to you. If you have a pen drive, I can transfer it to you. So that is actually the petrous apex, and I'm giving surgiflow, and that's the infralateral trunk. You can see that's the carotid artery. I'm bipolarizing the infralateral trunk. So there are two branches of the cavernous carotid. One is the meningohypophyseal trunk, and second is the infralateral trunk. So that's the infralateral trunk. And what we always do in a JNA involving the carotid is that we get proximal control and distal control. So I get a paraclival artery, paraclival carotid control here proximally, and I get a supraclinoid carotid distally. So even if there is an eventuality, I can go in for a carotid sacrifice. So you can see that now I'm trying to strip the JNA, and in fact, see that's a carotid artery. You can see that carotid artery pulsating. See that? And now I'm stripping the JNA right from that carotid. You can ask me, how can you do it from the carotid? If the carotid ruptures, what happens? Please understand that the carotid is not directly involved by a JNA. There is an endosteal layer over which the JNA will be sitting. So you can peel the JNA from the carotid. This is a very important carry-home message for everybody dealing with carotid involvement of JNA. Now, let us go to stage 4A. Again, this was another publication by us in the International Journal of Otolaryngology, a European journal. Now, imagine this JNA. It is going down. It is going right till the tonsillar fossa. You can see here, it's going right till the tonsillar fossa. How will you do it endoscopic? How do you do it endoscopic? So this is where I learned this technique from Professor Castelnuovo. He is one of the genius surgeons I have seen. So I learned multi-port technique, and we published this again. You can see that that is the tonsil, that's the uvula. So I'm making an incision. This is the first reported case in world literature of multi-port technique, and you can see that this is the tonsil, the anterior pillar, and you're operating between the superior constrictor and the medial pterygoid muscle, and then you can actually take the JNA gently and dissect it. And once you dissect it, what you will do, that's actually called the multi-port transoral approach to JNA. So you can approach the skull base through the oral cavity. These are all the current concepts of skull base. So what you are doing now is trying to get that JNA and then bring it, that's the foramen ovale region. Of course, an edited version might not give you a complete, but I can't post the whole video. So what I'm trying to do is to transect the JNA at the level of the foramen ovale. You see, I'm not using any cautery, nothing. I'm just cutting it with the scissors. I generally cut it with the scissors, and once you devascularize it, it doesn't bleed much. And then I'm pulling that into the nose. So the one which was in the tonsil is being pulled into the nose. So I'm delivering that JNA through the nasal cavity. You can see that that's coming out through the nasal cavity. These are all Indian JNAs. When I show it abroad, they even say that, oh my God, we don't see such JNAs at all. But yes, in India, we see a lot of them, a lot of advanced tumors. Now let us see, that's a postoperative scan showing complete removal. Stage 4B. Now, this again we published, the first ever reported in literature. You can see that this is the JNA involving the brain. So how do you deal with it endoscopically? So that's the tentorial branch of the meningohypophyseal trunk, and what we did, what is again called the multi-port approach. This is the multi-port approach. You can see that this is called transorbital approach. So we have now done 5 cases of transorbital approach. You can see that's a greater wing of sphenoid, and that's a port just lateral to the superior orbital fissure. So you get the superior orbital fissure, that's the dura of the middle cranial fossa, and then what we do is I incise the dura, and that's a tumor right in the temporal fossa. We use it for sphenoid-bearing meningiomas, arachnoid cysts of the temporal lobe, and all these things. Now we now trying to do microdissection and removing the tumor from the temporal fossa. I'm using cautery here, of course, because inside the brain we don't want any bleeding, and you can see that we are now trying to deliver this and the JNA out of the brain. And that's CSF leak after removal. And then you can see the post-op MRI showing a small residue here, because that was actually the tentorial branch. I transected it, and it was gamma knifed. So I sent it for a gamma knife later. This is the boy. You can see that the eye is moving, lateral rectus not involved. This is the only incision we used. There is nothing else we used for the boy. Okay, so we published all this. So now what next? What next to do in JNA? What's the next step? So then we thought we have to do something which is involving the carotid completely. So this is under publication, so we are going to publish this. These are the first 4 cases reported in literature. So now will be reported. We are just making papers out of it. So if it is engulfing the ICA, so imagine this is going to be the JNA. So the JNA going into the temporal fossa, totally into the temporal fossa. Can we do it endoscopic? Yes, we can do it endoscopic. Now let us see how we do it. You see, that's what we did. So this JNA, this is the ICA, cavernous ICA, JNA here and JNA here. So if I go endoscopic or from external approach, you're going to avulse the ICA and he's going to bleed to death. So what we did, we started thinking of 2 things, which Mario Sana, I'm sure everybody has heard about Mario Sana. He does stenting of the carotid. So he stents the carotid. So we started trying to explore that option in Trichy, and we have one of the best radiology department in our center. So we ordered for a stent, but we couldn't get a stent for the cavernous carotid. We get stents for clival carotid, paraclival carotid, but we don't get stents which are bent. So what we did was we thought of carotid sacrifice. So what we did was we coiled the carotid. So we are now coiling the carotid. See here, what we do now is, that's actually the radiologist who is coiling 2 parts. One is paraclival, the petrous part and the supraclinoidal part. And this carotid I can cut like this. I can cut this carotid like this, and I remove the tumor along with the carotid artery. So that is what we did in this case. You can see that we resected, and that's the temporal lobe. And of course, this is the post-operative scan. You can see that this patient, you can see the scan, completely resected carotid going into the temporal lobe. This was our first case. The second case was like this. So you can see that this is the tumor inside the temporal lobe, and completely on both sides of the carotid. You can see that this is, so people ask me, have you seen any JNA going intradurally? We have 6 cases now. 6 cases of JNA going, see that intracranial. This is actually ACA and MCA. It's going beyond the ACA MCA territory and involving the carotid going into the temporal lobe. So again, what we did, we now got a neurosurgeon to do a pterional approach from this side, and then we did a nasal approach from this side. So we attacked, I removed till the level of the cavernous sinus, and the neurosurgeon removed it. So that, what we did before was mapping the tumor 3-dimensionally. This is called the 3D mapping. You can see that now we are trying to map that tumor. Where is this going? Which hole? You can see that's actually the hole. That's a temporal lobe, and you can see that it is going like that. That's a greater wing of sphenoid. This is the tumor. So once we mapped it, we exactly knew where to make the craniotomy. So that's what we did, and then we coiled the carotid. So this is actually the coiling of the carotid. You can see that we are coiling that carotid there. So that's a coil. You can see that coil very clearly. So I can resect the carotid now. So we resected the carotid, and that is actually the video. Of course, I'm not going to play too many videos now. This is actually the pterional approach being done by the neurosurgeon. We have one of the best neurocenters in our place. Trichy is very famous for neurosurgery, and now you can see that this is tumor we have resected completely. This is the carotid completely coiled, and then we resected that tumor completely. And that's a post-operative scan. You can see that complete resection. Even now, the patient comes for follow-up. It's now around 1 year since we have operated, and the patient still comes for follow-up. And now this case 3, you can see that this is actually the tumor going into the brain. This is the carotid. And now, again, we coil the carotid. You can see that we are coiling this carotid here. So that's a coil of the carotid. Can you all see that very clearly? The coil of the carotid. And then we resected the carotid, and that's again the post-operative scan. And now, this is the 4th case we did recently, around 3 weeks back. We did it, and that's actually the tumor going into the brain. And we, sorry. So this is under publication now. So we will be publishing this, and this will be the first in literature again. So now this is the coiling of the carotid being done, and then you see how I dissect that. This is the kind of dissection we do. Absolutely almost bloodless, because we can go around the tumor. That's where it's going intracranial. So what I'll do is I'll segmentally resect this part and then remove it from nasally, that part. Okay, that's the post-operative CT. You can see that this is completely removed. You can see that the temporal lobe is completely exposed. We put a Hadad flap. So now that is the external approach. You can see some tumors. This was referred to me from Kerala, actually. This is a very memorable patient. He lived for around 1.5 years, after which he developed a recurrence. After 1.5 years, he developed a recurrence. But what we did for this case was a Janika. So Professor Uma, she referred this case. We did a Janika for this, bilateral maxillotomy, mandibulotomy, and then we removed the tumor. And you can see that that's the second case. I think this is, again, a very interesting case where we operated this case and by the Janika, and that's a post-operative picture. And so, you can ask me, you're talking just about your, achievements. What about your complications? We have a lot of complications. Please understand that in our center, almost every day, we face some complication because we're doing neurosurgery. So yesterday we had a petroclival meningioma. I operated. There was a small complication. But what I mean to say is every neurosurgery has a little bit of morbidity and some complication. But this is one complication I want to show you, and this is the only complication I had in my 300+ series of JNAs. You can see this patient was referred to me after 9 surgeries, after radiotherapy, and then they said, you operate. I didn't know where the anatomy was. This was a JNA going into the superior orbital fissure. Usually the JNA is covered, I told you, by endosteal layer of dura. So I started resecting this layer. So it was radiotherapy, so absolutely no anatomy. And you see what I'm doing now. I'm trying to cut that endosteal layer. But what happened was that was a carotid. And I had a massive carotid bleed. Of course, even for last week case, I told my assistant, get ready with the thigh. Whenever I go for the carotid, I always say, get ready with the thigh. And then one guy is always sitting there. The moment I say go, he'll make the incision, take quadriceps muscle, crush it and give me. And so what we do is immediate. This was actually managed around 1.5 years back with some cautery. I had to do a carotid sacrifice. Patient developed an MCA infarct. So patient developed an MCA infarct, and in fact the patient died after 18 days. So this JNA was the only mortality we had. After 18 days the patient died. So, but then, to conclude, what is the carry-home message? What is the carry-home message? I want to end it by saying 3 important things. Dr. Tyagi, there's nothing to write. You're just going to see something. So just read this book. It's all there. But the carry-home message is this. Sound, please. This is the first take-home message I want to give you. Don't think you are a breast surgeon. Don't preserve the turbinates. Don't touch the middle turbinate. And if you do that, this is what happens to you. So become a clear-cut skull-based surgeon. When you operate on a JNA, you are not a breast surgeon. You are a skull-based surgeon. Number 2, get your vascular control. So if you are in doubt, get the neck control. Have a bulldog clamp. Get a bulldog clamp, or else this is what happens. You see that? You will slide and fall when it's bleeding. Have complete knowledge of the ICA. How do you have knowledge of the ICA? It's like the cobra. So in Rajasthan there is a place where they train the cobra. So you should do something like this for the carotid. Just pull it and play football with the carotid. And if you can do that, then do JNAs with ICA. So this is what I always say, have complete knowledge of JNA and its anatomy before you operate on a JNA. So I think I'm sticking up to time, but it shows time up. I don't know what Professor Mukhtar has done to me. You gave me 1 hour and pushed me into 20 minutes. Thank you very much. Thank you. Thank you. Thank you. Namaste.
Thank you, Janakiram.
I just want only one thing. See, I am very patriotic, and I always believe it's being seen by the world. I know GLAD from, South Africa is seeing me. I know that Indonesians are seeing me. Right now, I am telling you, I am a very patriotic guy. And I feel that there are some tumors which are specific to regions. like JNA or maybe cholesteatomas. I don't know what other fields are. I don't know about it. But then we should be the authority in that. And I think every Indian should have that attitude and do a lot of innovative thought into it. And then we will be there in the world. We will be there. There is no doubt about it. And we all should do it together. Thank you very much. Thank you.
Thank you, Janakiram. Your mesmerizing talk. So, we actually, Janakiram, it is everyone is clapping now. For me, it is not new. 25 years back, his dissertation topic was middle turbinectomy in face surgery. 25 years back, what was the first stage? That is the early stage of the face surgery. Just we started face surgery. That time itself, we selected a topic, middle turbinectomy in face surgery. Then what he did? During his course, he went to veterinary college where his friend was there. He did turbinectomy in horse, dog, and all animals, and see the skull base. So for me, it is not new. So he is a well-known skull base surgeon. Your hats off, hats off.
Thank you, sir. Thank you, thank you. Actually, I think we should start with comparative anatomy. I always believe that, going to the veterinary college, I in fact even told my son actually this. So when you start with the amphibians and all this stuff, so that you really understand how man has evolved. And once you know exactly where we are, then we know where to go further. Because evolution, you get into evolution, and you don't stay on time. You evolute. So I think every scientist has to evolute. He has to go through evolution. And for that, he should understand all these small creatures and then go on into the next level, maybe gene therapy or stem cell therapy or whatever. But then, unless you understand what a dog is or a cat is or a horse is, I did that 25 years back, as my teacher said. So I think everybody, a youngster at least, should start thinking of evolution of mankind. So we can take some questions, moderator, sir?
Yes, you can.
So it's open for discussion. If you have any queries, comments, anything, you can share it. Do we have 10 minutes, Professor? Thank you. You can have the mic, please. Can you give the mic to him?
Come here.
I'm really surprised that you arranged it in Goa and so many people are sitting in Goa. It's really a fantastic achievement. Yeah.
Have you ever operated a JNA in 19 years female?
In what?
Have you ever operated a JNA in 19 years female?
19 years female is something difficult, but in females, I have not operated. I'm yet to see a JNA in a female. There are some reports in literature of JNA in females, but we've had arguments on various stages, like Italy, in London, in America, on what this real tumor which has been reported in the past is, and finally they land up in some other thing. If you do the, markers, I in fact sent you the markers. What are the markers for JNA? So if you do all that, I think maybe you may be right, but if you are right, you will be the first in the world to report it.
Oh,
so,
thank you.
Yeah, you will be the first in the world to report it.
I have a case I want to discuss with you. I have a case I want to discuss with you.
Please.
I have a slide.
Yeah. Yeah, Dr. Rajiv, please. It's like a family. Please ask any question. We are ready. We have a discussion here. Dr. Srinivas, you have any question?
Many people are using this cobbleter for debulking of the big angiofibroma.
Yeah.
Do you agree with this thing, or do you appreciate or not?
Yeah, it's a very good question. Actually, using the cobbleter. Yeah, I do it. I do it a lot of times. And you see, you can... My main concern in using diatomy or cobbleter or anything like that, so when you use cobbleter, what happens to the tissue is that the reddish tissue becomes brown or maybe whitish or some other color. So when you're applying it, imagine on the infratemporal fossa. These JNAs, what happens to the JNAs is that they have daughters, granddaughters, and small feet everywhere. They go like small feet. If you see the videos, I can give you any number of videos. They go into the crevices. My only concern is, if you have a big chunk of JNA and you want to resect that into two with a coblation, you can do it. There is no question about it. But when you're operating on its periphery, where it's getting attachment to the upper parapharyngeal space or lower parapharyngeal space or into the cavernous sinus, if you want to use a cobblator, you might leave behind remnants. So this is what is my concern. And overuse of cobblator can lead to massive recurrences. So this is my concern. You can use cobblator on the surface of the JNA. You can cut the JNA. I use a lot of diathermy to cut it into two. This is what is called, we also published it as the principle of segmental resection. This is called principle of segmental resection. So I'm telling you another thing. If you want, Dr. Rajiv, I can give you a video we operated a few days back. Whenever we do the cavernous sinus, if you have a huge JNA and do the cavernous sinus, if you're operating and it starts bleeding, you will not be able to go there. There's no space. So it's better to make it small. So resect it segmentally and make it as small as possible and then go and attack the vital structures. This is very well known. I fully agree with you by using the coblation to cut the JNA, but not in its periphery. When it's attached somewhere, don't go there and apply the coblation because you will not differentiate the tissue from the JNA. If it is firm, it's fine because it's going to come like a ball. If you pull, it's going to come like a ball. There are JNAs, if you pull, they are a little jelly-like, and so a part of it is left behind. And when you use the coblation, what happens is that this part comes out, this part is left behind. So these are potential, So you can also argue that there are papers which show regression, spontaneous regression. We had a big topic in some congress on spontaneous regression of JNA. And some said, why are you going and taking a risk on the cavernous sinus? Why don't you allow it? Please understand, I told them the same psychology. And I'm telling this in front of the world audience. Imagine a tumor which has got blood supply. You have a blood supply and you think in your mind it's going to regress. I think you have to take it with a pinch of salt. It has got its blood supply. If you have maybe a small tumor left only in the parapharyngeal space, everything gone, you have cobblated all around, maybe it can regress. But you can't expect a JNA which is sitting right with a big blood supply and saying that it's going to regress, let us leave it like that. Then I think there's something wrong in the concept of JNA. I think I'm putting my points across right? Okay. Yeah, please, Dr. Handa.
Yeah.
How
frequent you use?
Can you, I'm a little hard of hearing.
How frequent you use embolization?
Oh, that's a very good question. Beautiful question.
Immediate pre-op.
I understand your question. So this is again a big point of debate. Should we embolize? Should we not embolize a JNA? This is a point of big debate. So the proponents, I'll just tell you the world statistics. You can decide whether you want to embolize or not. Number one, the world proponents for embolization are those who feel that it will lose its blood supply. So when you cut, it's not going to bleed, right? Am I right? That's why you embolize the JNA. Number two, you can embolize only the external carotid artery territories. You cannot embolize internal carotid artery. Am I right?
Yeah.
Correct. Now, if you are going to embolize, the problem is that in 48 hours or 24 hours you take, what happens? You do a double-blind control study of embolized JNA versus non-embolized JNA. If you cut a JNA like that, you cut a JNA like that, you know the trees have got worlds. With the worlds, they find out the age of the tumor. Something like that has been done. The study on a JNA has been done. So the aging of the JNA, the periphery becomes fibrous and the center becomes very vascular. This is how a JNA actually grows, if you look at the pathology. Now, to answer your question, what happens to after embolization is that Professor Schick did a study. He has done a landmark paper. And he says all these granddaughter cysts become very thick. It becomes thick. These granddaughter cysts are not like glomus jugulare. They actually go into the crevices of the clivus. They go into the crevices of the Haversian system of the bone. The greater wing of sphenoid is filled with Haversian channels. So what happens is that it becomes thick. You do not dissect a JNA. You only give a mild pull. This is how gently we do a JNA. When you pull, if it is, imagine like a jelly, without embolization, it will just come out of that crevice. But if it has become tough, and if the neck is small, all these will remain inside. So Professor Schick confirmed that the incidence of recurrence after embolization is 8% higher than when you do it without embolization. Point number one. Point number two, if you go by a centrifugal approach, that means you attack the JNA and then go inside the JNA, you're going to meet with bleeding. Yeah. Okay? So what we are going to advocate to you is don't touch the JNA. You go around the JNA and then the IMAX supplies it, clip the IMAX. If you have the DPA, SPA supplying it, clip the DPA, SPA. So you do what is called a per-operative ligation of the vessels. The only vessel you cannot ligate per-operatively is the ascending pharyngeal. Apart from that, all the other branches of the IMAX can be ligated. So what except the middle meningeal, of course. So what happens is that what we do is a centripetal approach, clipping all these, and then we remove the tumor. So this is the advantage of doing it without embolization. But to answer your question, imagine a JNA sitting in the cheek. Okay? Now, where will the IMAX be? There are two routes which has been studied. It can go anterior, it can go posterior. We have seen both. We have seen posterior. So what we do is, if it's very vascular there, we just take a bulldog clamp. Just take a bulldog clamp and clamp the ECA, and then after the surgery, release it. Never ligate an ECA, just clamp and release it. That's it. So that's equivalent to your 40,000 or 50,000 embolization. There's nothing big about embolization. So I think this is not a topic which, like, the world discusses, you have to embolize, no embolize. We now embolize the ICA. Now we are talking about stenting of ICAs. So where's the question of embolization of ECAs? Of course, you can do it whatever way you want. If you want to embolize it, do it. But only thing is the incidence of recurrence will be 8% higher in your embolized JNAs.
That's right.
Yes.
Plus it is expensive. And it is expensive.
It is?
Expensive.
Yeah. Cost factor, I didn't even talk because, we take it for granted that the patient can afford it. Yeah. Yes, Professor Handa.
You do check CT or MRI on day 3. Any experience of intraoperative MRI?
Oh, very, very good question. Unfortunately, I am one of the poor lot here who can't afford an intraoperative MRI. But if it is there, then maybe, yes, I can try that. But believe me, the quality of... So we also had a debate with Professor Kassam. So Professor Sethi may be watching now. I gave him a message. Maybe he's also watching. He also has an intraoperative MRI in Singapore General Hospital. So what happens is that the quality of the intraoperative images are not very good. If you look at it, it's not like the 3 Tesla images or something like that. So if you leave behind a very small residue during surgery, it is not very well picked up, even in pituitary or something like that. Maybe the advances in MRI will give you the answer. If you have an intraoperative MRI, well and good. But I have no personal experience on this. I'm sorry. But do you have one? Then it's the best situation for any skull-based tumor. It's the best situation. Yes. So any other questions before we go to Dr. Tyagi?
Any questions?
Yes. Oh, the Don is there. Yeah.
I had to wait and sit because you left me speechless. So I was getting my voice back before I could ask you something. You speak about 36 hours later in MRI, right? For the residue.
Not MRI, CT. CT with contrast.
CT MRI. CT for the residue.
With contrast.
Okay. CT with contrast.
Yes.
Now,
CT.
Yeah. You decide on the basis of that you're going to go back in again and remove that bit of residue?
Good question. Very good question. Very good question. So, his question was, just to make you understand that question, he says, if you find a residue, will you go back and operate? So the answer to that is 2 ways. One, there are residues which we leave behind on purpose. For example, the patient does not give a high-risk consent. He says, oh, the ICA, don't operate. Then what we do is we leave behind that residue. In that, we take the post-operative MRI, show him, and then send him to the gamma knife. But every surgeon cannot be God or cannot be perfect, so he will leave behind a residue somewhere. So this is why I insist that you take a post 36-hour CCT, and then within 10 days or 15 days before the patient gets discharged, we go again and operate.
Yeah, so that's my point. So let's say you do the CT and you decide there's a residue. Now, on what basis do you decide that this residue I'm going to go back inside and remove, or this residue I'm sending for a gamma knife?
Yeah, that is a very good question. Again, it depends on the location of the residue and the consent of the patient. So, and the competence of the surgeon. I underline that finally. So, what I mean to say is, if you have left behind a residue in the infratemporal fossa, then there's nothing. You can just go inside, just take it. It's going to be a maybe 15 minutes or 20 minutes job. But if you have left behind in the cavernous sinus, in fact in the lateral compartment, so we had another argument between compartments of the cavernous sinus, which compartment will you go back? I would think about going into the lateral compartment because of the incidence of 6th nerve, 3rd nerve, 4th nerve palsies, and so I might leave it for a gamma knife. But if it's going to be in the anterior inferior compartment or the medial compartment, which is very rare, or the posterior compartment, I would still go ahead. If it is inadvertent, go ahead and operate. So it depends on the location, it depends on the risk, consent of the patient, and number 3, the competence of the surgeon. These are the factors.
Perfect. Thank you very much. I told you day before yesterday you're going to be here. That case would not have stopped you from coming. Thanks for coming, Daniel.
Thank you very much. Thank you. Yes, I think we can go on with, yeah. You want to show some case?
Yes.
Yeah, please.
I want to start my case. If you and sir approves, it may be a wonder in...
No, I'm not yet approved. Please, don't take me for granted. I've still not seen the case also. Maybe some AY group you have posted, I don't know, but I have not seen the case or I have not given any sort of approval. I am not an authority, first of all, to approve. So that's very clear.
I want to just start the PPT. It is a female of 19 years. I have operated 3 weeks back. I have sent all the scan report to all the stalwarts, to all the groups, AOI groups and all ENT groups. They all said it might be a JNA, and I have operated on that girl and sent all my tissue to histopathology. A senior histopathologist from NCR. You might know the name. She is Mithilesh Chandra. She is very senior in NCR, and she told me, Tyagi, it is 100% a juvenile nasopharyngeal angiofibroma, and I am sending some ISC markers to the US. But you can present the case in any CME. So here it is. This is the endoscopic picture. This is proptosis, bleeds on touch. These are the scans. Pointer.
You want to comment on this? It's going to be something like an examination then. I'm leaving it now. Okay, fine. Right.
These are the scans.
Now, can you go one scan back? Okay. Dr. Raji, you want to comment? No comments. Huh?
Anthony, what's your comment?
Any comment about Ram Arun sign in this case?
Yeah, you want me to comment?
Yes.
Yeah, so we will see this scan very critically. I'm sorry if I'm, I don't know. I'm going to give you my opinion. First of all, you don't have a posterior cut here. So I can see only till the level of the inferior orbital fissure. There's no pterygoid plates. You have not taken the pterygoid wedge. For me, it's very important to see the pterygoid wedge. And number two is that you can see the spread of this tumor, whatever tumor it is, you can see the spread. You can see that this part of the orbit is involved here.
Yeah.
Okay? It's involving the orbit. Yes, JNAs can do this. It can push the orbit. It can, it very rarely erodes the lamina papyracea. If you look at that, it actually goes through the inferior orbital fissure into the orbit. And it doesn't go like this. So, number one. Number two is that you can see that there is, I cannot see the sphenopalatine foramen and the pterygopalatine fossa. So, I'm not able to comment. But here, if I see the axials, there's absolutely no involvement of the, see, that's the sphenopalatine foramen here. So, absolutely, so there's one entity called extra nasopharyngeal manifestations of JNA. If you look at the papers, they have sort of, extra nasopharyngeal manifestations. There are several articles on that. Even females have been reported. They're not typical JNAs. They are atypical manifestations of JNA. And if you are going to put your case in that, then I'm sorry, you might not be the first. So you might have n number of cases which have been already reported in literature. So you might still be a JNA, but then this is not a typical CT scan appearance of a JNA. This is my view. I'm sorry if I'm not the authority, but you can ask maybe Karao. You can ask Professor Karao. He is the authority, or you can ask Professor Sethi. Yeah, you can carry on. Next. So where is the MRI with contrast? So you can see here that this is again the maxillary sinus. It's going right from the maxillary sinus. You can see that medial wall is completely eroded going into the maxillary. This secretions here. It is very rare for a JNA to, without going from the posterior wall, going through the medial wall into the maxilla. I'm not very sure about that. So again, points for and against. So this is definitely a contrast enhancing mass. I can see that. And this is the central necrosis. You can see the central necrosis here. Dr. Anthony, you want to comment on this? See the central necrosis here. There's peripheral enhancement here. What do you think it could be?
It should be a rhabdomyo.
Yeah,
something like this.
That's the closest DVD.
Yeah, but immunohistochemistry will tell you what exactly is that.
Yeah, IHC will tell you. So what are the IHCs you have done? What are the markers you have done?
Androgen receptor.
No, but did you do the CD14, CD31 and all this stuff? Did you do the actin receptors?
I have done all the ISC markers.
Okay.
They are still awaited.
Okay.
All the ISC markers.
Okay. Then
all
I think we cannot come until the ISC markers come. Until then, we'll have to wait. So that's my comment. But anyway, a very interesting case.
And this is the external cavity ligation.
Again, I'm sorry, I disagree with you on ligation. Now I don't ligate. We only clamp the ECA, because if you ligate, what happens is that it gets its blood supply from the ICA territory. So that's something. Anyway. Nasopharynx? Yeah.
This is nasopharyngeal part.
Okay. This one? This is the JNA? Pardon? This is the JNA? In the nasopharynx? You mean this is the JNA? This doesn't look to me like a JNA at all.
Okay.
Yeah, basically it's a mass which is in the nasal cavity, nasopharynx, goes inside the maxilla, goes inside the ethmoids and into the orbit. It's a tumor which is in the ethmoid area, centric, spread in all directions. Looks like a, what's the duration?
And this is histopathological.
What is the duration?
Histopathological report.
No, histopathology, how many of you have got reports about JNA in the audience? Like, Dr. Handa, can you comment on this?
See, even if you are saying, showing a lot of vascular spaces akin to JNA, we have had diagnoses like angiosarcoma, where the spread of JNA is not there, but you may have had some bleeding and this sort of a spread. So, the radiology picture, the morphological picture doesn't match a JNA.
Okay.
And all the more it's a female.
And this is histopathological report.
Okay, it's a very good case. Thank you very much.
Thank you.
Yeah.